Hi, good morning, everybody. Today we'll talk about cervical cancer in pregnancy or diagnosed during pregnancy, which is quite uncommon but not very rare disease, especially in our community where you have patients who had never did the pap smear in the past. Sorry for the voice, by the way, and sorry for the delay. There was some technical issues with my voice over the weekend. Today we'll talk briefly about the presentation, signs and symptoms, and then hopefully all of you did review the lecture of cervical cancer, so you can combine it for the management of cervical cancer in pregnancy. So we'll have a brief introduction and then signs and symptoms for a patient with cervical cancer during pregnancy, the treatment dilemma, and how to counsel the couples or the patient who is diagnosed with cervical cancer during pregnancy. And then we'll talk about the management as per stage and then post-treatment follow-ups. Cervical cancer in general, it's the fourth cancer diagnosed in female, roughly around 15%, but as we can tell, there's a major difference between developing and developed countries, and this is basically because of the vaccine and because of the screening program. The incidence during pregnancy is 1 to 3% of all cervical cancer diagnosed, which is roughly 1.8 to 1.5 case per 10,000 birth. Mostly diagnosed in early stages if you have it during the antenatal care. However, there is a delays in the diagnosis, and usually the delays in diagnosis because we refer the patient as bleeding because of her obstetrical cause rather than gynecological cause, and then the treatment as well will be delayed. The problem with cervical cancer in pregnancy, there is a limited data for sure. You cannot do randomized controlled trials. Ethically, it will not be correct. The risk of modifying the standards in treating cervical cancer during pregnancy, we cannot do risk assessment meaning you cannot tell the patient if we did treatment or individualize the treatment as per patient, as per gestational age, as well as the desire to continue the pregnancy. So autonomy, weight, what is the risk, how much it will be worth, the survival, etc., the control of disease. And again, we have to tailor the in these cases plays a major role, so you have to have a very proper counseling, and you keep in mind the stage of cancer as well as the stage of gestational age, and the desire of the patient and the husband to keep the pregnancy or to continue the pregnancy. We can see here the good news is there is an equal outcome, meaning survival if you compare stage to stage in pregnant or non-pregnant patient with cervical cancer. Patient may present with any type of bleeding, as we know that there is a recommendation to do pap smear in the first antenatal visit, so they might be asymptomatic with abnormal pap smear, or patient may present with any type of abnormal bleeding post-coital, intermenstrual, prolonged, early pregnancy, any type of bleeding, and then you refer the patient seek directed cancer diagnosis, or it could be what you call it colposcopic directed biopsy for examination and investigation, and then it is diagnosed, but we have to have a tissue diagnosis, meaning a biopsy directed biopsy. And always stage your patient clinically. It's equal or equivalent or similar to the non-pregnant patient staging system. However, if you remember, we spoke about the allowed or permitted examinations, investigations to do. In this case, we have a different modalities where you are not allowed to do endocervical cortage. It is not allowed to do hysteroscopy and DNC and also IVP. So the three modalities where you cannot use it to stage your patients are ECC, hysteroscopy, as well as IVP. Apart from that, you can do everything to stage your patient clinically. During pregnancy, you can do colposcopy, you can do cervical biopsies, but again, you shouldn't do ECC as I said before. It might be a bit tricky, has to be done by a gynecologic oncologist because of the laxity of the vagina during the examination, as well as there might be some abnormal findings related to pregnancy, not related to cancer, where it might be exaggerated during the exam. So you can do a cone biopsy. We prefer doing what you call it coin biopsy, meaning a shallow cone, not a deeper one. And at the same time, you can do an MRI, which really helps to determine the tumor size, spread beyond the cervix, as well as lymph node involvement. So MRI usually for staging. There is a debate about gadolinium or the dye which we use, but I think there's no problem with that, or you can do it even without it. Briefly about or around the management of non-pregnant patient with cervical cancer. It will be a quick review, and that will cover the areas where we're going to treat the patient with cervical cancer during pregnancy. Are three types of hysterectomies. We have simple hysterectomy, modified radical, as well as radical hysterectomy. And if you go to the speech about the cervical cancer in general, we did explain each and every one as a difference between the three entities. In general, stage 1A1, this is where you have the invasion less than 3 millimeters and the width of 7 millimeters. This is the only stage where we can treat it by conization or simple hysterectomy after a negative cone. So you can do a cone biopsy, you can do a simple hysterectomy. It depends upon the patient if she did complete her family or not. However, this is the only stage where you don't need to do lymphadenectomy. The likelihood of lymph node involvement is very low. Stage 1A2, this is where you have the depth of invasion is 3 to 5 millimeters. You can do modified radical hysterectomy, and then it depends if the patient wants to preserve her fertility and she did not complete her family. You can do what you call it radical trachelectomy. So radical trachelectomy is the radical removal of the cervix with a parametria, and then you suture the isthmic part of the uterus to the vagina. It is very well reported with more than 85 to 90 babies delivered after a radical trachelectomy. And this is one way of what you call it fertility sparing surgery. If the patient completed her family, you can just go for modified radical hysterectomy with lymphadenectomy for sure. 1B1, if this is the cervix is less than 4 centimeter gross lesion, this is you can do radical hysterectomy with pelvic lymphadenectomy. We should know that the term bilateral salpingio-oophorectomy is not part of the radical hysterectomy, meaning if you have a young patient, you can keep the ovaries. The ovaries are not part of the surgery. The likelihood of ovarian involvement is only 1.3 to 1.7%, which is very low. But the surgery has an advantages, and as you can see, these are the advantages. Part if the patient is a surgical candidate for radical hysterectomy. And again, you're gonna preserve the ovarian function. You can have the initial disease out when you have a proper staging. So everybody should push for the surgery. So stage 1B2, this is a bulky cervix more than 4 centimeters. There is a big debate about it. We used to do it as radical, and then the patient will require radiation after that. So everybody is backing up doing surgery as a primary surgery. The ideal scenario, I think you can just refer the patient for a neoadjuvant chemoradiation, and then if there is a residual disease, you can do a simple hysterectomy, or you can do a radical hysterectomy with pelvic lymphadenectomy followed by chemoradiation. And then if there is a residual disease after the completion of the treatment, we can do a simple hysterectomy without lymph node. Depends upon the surgeon, and there is like an individualized cases. But if the cervix is bulky, in my opinion, I would give chemoradiation. Stage 2B up to 4A, you can do radiation therapy. That will be the options here. There is no surgeries at all. You can give the patient external beam radiation, meaning like you can give 25 sessions every day except weekends, followed by 3 sessions of brachytherapy. Brachy meaning nearby, so you can give 3 sessions of brachytherapy, intracavitary radiation therapy in a weekly basis. That will complete the treatment of radiation therapy. Patient with advanced disease, you can consider like stage 4A, you can consider ruling out distant metastasis. If it's only localized or locally advanced, you can consider pelvic exenteration. If it's distant metastasis, you can give the patient palliative radiation or palliative chemotherapy. Remember, pelvic exenteration, we are aiming toward curative exenteration, not a palliative exenteration. Honestly, palliative concentration, I don't think it's ethically correct, knowing the move the entire pelvic structures, and you create a colostomy and ileal conduit for the urination and for the bowel. movements. So and the mortality. So you do a curative exenteration where you remove the bladder, the bowel, I mean the sigmoid, rectum, and the distal ureters. If you're gonna do a major procedure or such a procedure, it's not worth doing it only for palliative intention. You do it for a curative intention. Now we're going to talk about the management in pregnancy. Remember that the two determining factors in the management of cervical cancer in pregnancies are the stage of disease as well as gestational age. Remember, there is a lots of psychological issues when you have a patient who's pregnant with cancer. You need to have a very proper counseling, detailed counseling. It's a multidisciplinary approach where you need a maternal-fetal medicine, neonatologist, psychiatrist, maybe gyne-oncologist for sure, as well as you need both partners, meaning the dad and the patient, to be there. They are part of the discussion, and you have to have a disclosure, meaning you tell the patient what you know exactly, and you don't guess. You tell the patient if you don't know, because most of the time we cannot do risk assessment, and by the end of the day, remember, it's autonomy. Patients wish this is what you're gonna follow. It's not the patient's family, not the husband, not anybody, but the patient. So whatever she choose, you go with. So this is the management again in a patient during pregnancy. Patient may present with abnormal pap smear. If you have ASCAS or low grade, you can refer the patient for colposcopic assessment. But again, it's an option to keep the patient till she delivers, and then you can do the colposcopic assessment. It's not very urgent unless it's a high grade or H cell. So this is an exception here. ASCAS and LCL, you can wait till the end of delivery, sorry, end of pregnancy, and then you can reassess by colposcopic assessment 4 to 6 weeks after delivery. However, you can do colposcopy, but as we said before, if you have ASC-H or high grade or atypical glandular cells, this is where you need to refer the patient for colposcopic assessment. And remember that you cannot do a cone biopsy. Sorry, you try to do a coin biopsy, or what you call it, very gentle, superficial. But usually, you don't need to run or rush for a cone biopsy unless you think there is a severe dysplasia or there is a questionable microinvasion or carcinoma in situ. Because we know that there is a risk of pregnancy loss, bleeding, complications related to the cone biopsy, especially during pregnancy. So you keep that option only if it's really indicated. Now we have a case which is confirmed to be cervical cancer, stage 1A1. This is microinvasive disease confirmed by a cone biopsy or coin biopsy during pregnancy. Advanced disease, as I said before, it depends upon the two main factors: stage of disease, duration of pregnancy. We kept on saying that during the entire presentation. The margins were negative. You can just follow the patient till term, you offer the patient vaginal delivery, and then you treat accordingly if needed. If you have a motion, because that will determine the next step of management. If, if it's less than 22 weeks, you need to treat the patient without a delay, because that should show an impact on the survival if you wait longer time, impact on the progressive disease as well as prognosis. However, if you have a patient beyond the 30 weeks, you can just wait for fetal lung maturity. You can give steroids, and then around 34 to 35 weeks, you can consider the ideal management according to what we mentioned. So if she needs a radical hysterectomy, you can do a cesarean radical hysterectomy. If she needs a simple hysterectomy, you can do a cesarean hysterectomy. It depends upon which stage of disease you diagnosed, and again, you can treat accordingly after the maturity of the baby. So the dilemma or the problem when you have a patient between 22 and 30 weeks, this is where you have a lots of debate, and you need to check, I mean, other factors to determine where should you go. And we think that doing imaging by MRI may help in determining is it an advanced disease or locally early disease. So by doing an MRI, sometimes it helps by checking the lymph node status, stage 1B1 and the bulk of the tumor is less than 2 centimeters and there is no lymph nodes by imaging, questionable. I don't think we go for laparoscopic lymphadenectomy. However, you can just follow the imaging and find out. If you think it's an early disease, like, you can wait. It might be an option. You can wait, but as I said before, you cannot give the patient exactly as a risk assessment. However, from what you get as an information. So as I said before, we cannot give a risk assessment, but it might be an option to wait if you think there is no extra uterine disease, lymph nodes were not suspicious, so you may wait till she reaches maturity with or without chemotherapy. We know that all the chemo therapeutic agents we used in obstetrics or gynecology, it's a class D, it is not X. So it might be an option to give the patient during the second trimester chemotherapy to have a distal control and to slow down the growth and hopefully to downstage it till delivery, and then you will continue with the proper management. Sometimes you have a stage 1B1 again, like a cervix more than 2 centimeters. It's locally advanced, but the patient during the second trimester, if the patient refused termination, and this is where you may consider giving the patient chemotherapy while waiting. CT is not a CT scan, it's a chemotherapy. So giving the patient chemotherapy while waiting, and you can wait for a few weeks. Ideally, after the last dose of chemotherapy, you have to wait for 3 weeks to consider the surgical option after the recovery of the white count and the hemoglobin. And you can do a classical cesarean section, and after that you treat the patient accordingly if she needs radiation therapy or not. But as I said before, remember, if you want to wait, make sure it's a normal fetus, it's not a baby who's affected by any chromosomal anomalies or anything else. The ideal management. Let's say the patient told you can do whatever you think it's good for me. This is the ideal management. Less than stage 2A, as if she's not pregnant, you go with a radical hysterectomy with the fetus in utero. If it's less than 22 weeks, you do a radical hysterectomy after a CS if it's a viable fetus. And if it's an advanced disease, you give the patient radiation therapy, external beam. Most of the time, there'll be a spontaneous resolution or abortion. However, the abortion happens within 4 to 6 weeks. If not, you can do hysterotomy, remove the fetus, and then you can also do evaluation of the lymph nodes, and then you proceed with brachytherapy after the completion of the external beam radiation. Do a post-treatment surveillance every 3 or 6 months or a year. This is what you need to do. You need to do a complete physical examination and a proper history, and then you don't need to do imaging. And we always tell everybody, restrict the imaging modalities only if the patient gave a new symptoms or your examination was abnormal or your investigations were abnormal, meaning you did a pap smear or a tumor markers were abnormal. You do investigations like a CT scan or MRI. You examine the patient, there was abnormal findings, you do an investigations like a CT or MRI, but you don't do it routinely on each and every visit. This is the indications to do imaging, but in general, you need to do a pap smear and complete physical examination as well a proper history. Thank you very much.